So the first project that we have to offer is a charge master review. And the purpose will be to review the hospital's charge master and implement guidance on CDM management process for the hospital. What the goal of this project would be is to provide a consistent and defensible pricing strategy through CDM management. And the results of this project would be that we would have action items, that the hospital would have an up-to-date charge master and a strategy for maintaining consistent and defensible pricing strategy. Now that pricing transparency, everyone is going to have to load their prices online as of January 1st. Patients are going to be more apt to going and looking at it and questioning that information that's out there. And so what the CDM management project would do is to allow the hospital to have a consistent pricing methodology and to be able to defend it to the patient. The outcome that we are looking for this, it would be that they would have a report that would review the findings, outlining the recommendations for how to manage their CDM, have an action plan for CDM maintenance, because it's not just a one-time thing. CDMs are live and breathing and new charges are getting added all the time. And then also to have a training on ways to eliminate pricing variability. Because what happens now when we look at these CDMs, we see that the same service could be done in 3 different departments and have 3 different charges. Yet when you look at that service, does it cost 3 different amounts to perform it? And typically it doesn't. And so it's a way to help eliminate that pricing variability. And then establish a cadence for actions to keep that consistency within the facility itself. The anticipated outcome is that the hospitals will have a consistent current policy for their CDM. It will be a defensible one. And the way that we will do this is we compare their CDM to the current Medicare fee schedules. So we're updating everything as of January 1 to the 2021 pricing. The available CPT codes that the AMA has added or deleted will be included in those new analysis as of 2021. And that way we're helping the hospitals. They don't have to go out and pull the manual. They can work with us to identify that information. We'll train them on the key elements in a CDM and how they relate to one another, that you do have the same service that's in multiple departments. We help give them instructions on how to eliminate pricing variability and then create a cadence for that consistency within it. We expect that the timeline for this project is a 90-day project. From the time that we sign the agreement and get the data from them, we should be able to have the results returned to that hospital within 90 days at the latest. The next project that we have out there is related to revenue cycle management and oversight. And this is a new area that we are bringing with Stroudwater, is to help provide a formal strategy and guidance for the oversight of the key aspects of a hospital's revenue cycle process. So the goal is to use their existing reports that are in the system. They have an AR system that's tracking this information, but to train the leaders, the CFO, the revenue cycle managers on how to monitor the activity from both a financial perspective as well as a process perspective, and then identify the trends and issues that happen earlier in the process so that it doesn't exacerbate an issue when they find it 6-9 months later. The objective of this is really that revenue cycle, people think about it as mainly a back-end process. It really occurs from the very beginning, the beginning with provider enrollment. If your providers are not enrolled, you're not going to get paid. Revenue cycle works with you on that, works with a CDM establishment. In the middle, that may be when people start thinking that revenue cycle happens with patient pre-registration, charge capture, coding, those are the things that are happening. And then in the end, with the final bill that's dropped, final diagnosis, AR management, denials and payments. That's an area that we really want to help the hospitals focus on, is in the denial and payment area, because while cash flow is good, if you don't get paid that cash through revenue cycle, cash flow is, you don't have the cash coming in to have a good cash flow. So what we will do is work with the hospital to identify 3 areas that they want to focus on, and then through that help create tracking mechanisms and ways to monitor the performance and help them identify issues that occur in the process and where to do it. The output, we will help them have a report that details the key revenue cycle reports to use it. So we'll be using their tools, their system, but help them identify that. And then an action plan for consistent review of the data on a monthly basis. What are they doing? What are they looking at? And who are they working with to help address the issues that are there? And then training on ways to identify these issues and the trends within the data that they are seeing, which will lead to fewer delays in cash collections. The anticipated outcome is that the hospital will have a formal process in place to manage revenue cycle performance. And we will do this by working with the hospitals again, using their available information, train the hospital on how to utilize the reports, because a lot of times they have the reports, they just don't know what to do with them. So we're going to train them on how to utilize these reports and then educate the users on how to identify issues that come within those processes. This project, we think, would occur 60 to 90 days post capture of 3 months worth of revenue, 3 months worth of reporting. So it could be that they accepted this project in January. If they can get information from October, November, December, we can work on the project then. If they don't have that information available on January 1, then we would capture the information for 3 months, and then 60 to 90 days after that, the project would be completed. So those are the two projects with revenue cycle management that everyone's excited to talk about. Okay, just me, but do y'all have any questions for me?
I happen to really like it. I like it because it really meets the sort of the real goal of this particular program, and not only for process improvement, but the key piece of this particular program focuses on skill building for sustainability. And I think this is a really great fit. So we'll definitely, this is very helpful. And I think it's a great tie-in so that, you know, Ms. Dutton here, she's really going to be the person to help us with ongoing leadership management training. So I can easily see her helping to provide some additional management training, you know, to that department to help move it forward.
And
so,
it's
fantastic.
And as I recognize that, I mean, people really don't care about revenue cycle, except for people who are in revenue cycle. But if there are problems that occur in the front end, if the provider's not enrolled, it just rolls downhill. And, you know, one day somebody looks and says, why are we not getting payment? Well, that provider is not enrolled, and here's what we need to do. And here's why your job and your front end activities are so key for the back end.
And please know, we send, I feel like everyone on this call send a strong message that if they want to improve quality, if they want to improve on the financial position, then yes, got to do it together, and it's through revenue cycle. So you have a strong support here.
Thank you.
Great, thanks, Amy. All right, and Opal's up.
Look at Amy getting us right back on schedule when Eric got us off. So kudos to Amy for that. So talking about, as I said earlier, I lead our.
Where we all put our head down and our arms and take a nap.
Oh, Eric, we're going to be talking about physicians who are so much fun to work with. As my husband says, I'm a kindergarten teacher. Hospital administration and physicians and play nice in their sandbox and share their toys. That is what I do. So I am a glorified kindergarten teacher. And I love doing it. So let's talk first off about the practices themselves and the work that we're going to do with throughput and operations. So in my experience, right, to maintain access to healthcare across our communities, we have to be focused on those outpatient clinics. It's not, care is no longer solely provided in the hospital. Hospitals know this. They've been acquiring clinics over the years in a variety of different ways, whether it's bringing in providers to set up a practice, or if it's acquiring independent clinics that they've had relationships with over time. And the consequence of when we have this mishmash oftentimes of bringing in practices, it usually isn't done in a very thought out and strategic way. It's a physician calls up a CEO and says, hey, I don't want to do the day-to-day operations anymore. Will you buy my clinic? Yes, we don't want to lose this provider and the fantastic, we have a great relationship. Sure, I'll buy your clinic. That happens over and over again. And we realize next thing we know, we have all these clinics who are running in a completely different model. None of them are coordinating with one another. If you have multiple clinics, and then we get in it and we get, as a hospital administrator, where I realized I don't really know how to run a clinic and I'm not sure whether or not the clinic's doing well. So you need somebody to come in and tell you whether or not you have a cute baby, your clinic, or, you know, maybe it's not the cutest baby, maybe it's an ugly baby, or maybe you already know that there's a problem. We're losing so much money. I've got to answer to my board about, we've got to be doing better in these clinics because we're losing money in them. So we get those phone calls from both of, hey, I have no idea how my clinic's performing, to, hey, I know it's a problem, but I'm not sure how to fix it. And so when we do these diagnostic tools for the clinics, most of the clinics that we work with, you know, they're going to have their problem. There's a few areas, right? It's how you have your alignment set up with your providers, how you set their compensation up. It may be how you're utilizing your APPs. It might be, maybe you don't have the insight of knowing how to, as I work with Amy a lot on these types of things, as far as you don't have the right metrics to know how things are going. And so you're not monitoring the information and the data correctly to know how to be able to make some decisions off of it. So we go through, it might be your staffing, you might be understaffed, you might not have the right people in the right positions, providing the right services in a clinic. And sometimes it's a matter of your EHR system really is the headache that everybody thinks it is, but you're stuck with it. And so how can we utilize it better? So on these projects, what we do is we ask for a bunch of the data so I can figure out what are the things that are giving you the biggest headache. And sometimes it's not what you think it is, right? So that's why I ask for an extensive data request to look at the practice financials, but what are the different operational things that are going on in the practice? I meet with the physicians themselves, the advanced practice providers, I talk to administration, and I talk to staff, so that it's not just a black and white picture. We want the full color spectrum of what is going on. And when we do that, we can usually figure out, right, here are the top couple of areas that if you focused on, the clinics will work better. Sometimes it's a matter of having a communication plan that is set forth. You know, the RHC system says you have to have monthly meetings, but it doesn't outline how do you make those meetings truly productive. What should you be covering? What kind of training should you be doing in those meetings to make the practices run well? So that might be one of the recommendations that comes out of it. It might be training to put together that dashboard that tells you here are the metrics that you need to be covering. It might be your compensation agreements with your providers don't make sense for the way that you're reimbursed. So we need to help you transition your compensation that in a way that actually matches the way that you're getting reimbursed. So if you've already moved down Eric's famous shaky bridge over to more value-based payments, your compensation agreements with your providers should reflect that. If you have a bunch of brand new providers, it might make sense to have a different compensation arrangement for them. So that's where the lawyer in me goes through and reads all of your contracts and finds issues with them as well, if there's those. It may be a matter of your state regulations allow you to use APPs in a different way, since that's different from state to state, exactly how to use that. So I like working with our clinical team of Louise and Carla and Lindsay sometimes, that maybe we need to have some training on how we supervise our APPs so that we can use them at the best degree of their license as well. So going through and actually doing this kind of diagnostic tool can give guidance to a hospital that doesn't really know how to run its clinics, or may have some good ideas, but needs a little bit of structural changes to be able to actually implement them. When we do this, we like to actually come up with an action plan for that hospital of, yes, here's your list of recommendations, but here's the top 3 things that we think are going to have the biggest impact. Here's the resources you're going to need to be able to implement this. Here's who out of your team should be responsible for it. And realistically, what is it going to take to actually implement that? So it's not just a report that sits in a desk that has recommendations. They come out of it with a plan of, here's what we need to focus on, and here's how we can go about doing it. So that's on the practice side. Like I said, it's a full diagnostic tool. We do have something that is more specific with regards to compensation that we've worked with some of the hospitals. I know Eric already mentioned working with Randy over at Picnicville. This is the next slide, Lindsay.
Yeah, I just want to also add that all of these services can be done virtually too. So there does not need to have some on-site component to it if the state of the world remains as is. So just to point that out.
Yeah. Well, and thank you, Lindsay, for bringing that up. When it comes to the practice throughput and operations, yes, it can all be done virtually. The one thing that we prefer not to do virtually, that is if we have to do a lot of EHR change-ups. because we need to go through a specific agreement to be able to see somebody's computer screen with their EHR if there's some specific things. You can't do that as well, like over FaceTime, over Zoom, without making sure we're all the HIPAA compliance aspects. So sometimes the EHR has to be a little bit more high level in a virtual setting versus if they need to do some specific EHR training, we do that as a separate engagement, because we have to go through a bunch of other compliance issues to be able to do that. All right. With regards to the provider compensation, you guys might have been, well, probably, as Amy said, I'm the only one probably who nerded out who's reading the updated Stark and anti-kickback rules that just got published and finalized recently, as well as the physician fee schedule that got published on Tuesday morning. Eric probably reads them, all 683 pages of it, but I'm not sure whether or not he did, or if he's read it yet.
Not this time, not this time.
But you know, one of the things is that when it comes to financial incentives for providers, this is heavily, heavily regulated, right? And the problem is the cost of compliance is shutting down hospitals. And it used to, some people thought, oh, they only go after the big guns. But as we've seen recently, the OIG made a commitment 2 years ago to pay attention to rural healthcare. And the problem is too many people are saying, okay, well, as long as I'm doing MGMA median, that's fine. MGMA, all the surveys, they're fantastic resources, but they don't know what's going on specifically in rural hospitals. And so if you just rely on survey data to give you your guidance as to what you should do for compensation or whether or not you're being in compliance with Stark and anti-kickback laws, it can get you into trouble. And unfortunately, these laws are not intent-based. There's lots of technical violations. Just earlier this year, Cookeville Medical Center, which is not far from where I live in Nashville, Tennessee, just got hit with over a $4 million settlement, which is not what they needed right before the pandemic, for something that was a technical violation. It was not intent-based. They didn't know that they did something wrong, right? And so they had to settle for that. Most of the hospitals that we work with, a $4 million hit is not easily survivable, right? That would close a lot of our organizations and ruin access to patient care. So when we look about that, that's the scary picture. But the other piece is a lot of times the way we pay physicians is just because that's how we've always paid them. And it doesn't make sense with how the hospital is actually reimbursed. If you're moving towards value-based, or if you're on cost-based reimbursement, your compensation model, if it doesn't reflect that, then you have an alignment problem. The hospital's strategy and that healthcare strategy for that system, we're not being incentivized the same way. And when I see that happen, oftentimes I see a lot more arguments between administration and physicians. So, you know, regardless of what happens with regulations, I care about having people on the same page and having a really strong alignment with my providers, that I don't pay for what I don't get paid for. And I want us to all be singing from the same hymnal and moving healthcare in the same direction. We should all be on the same strategy. And compensation is one of the key things to be able to do that. So we want to make sure it's in compliance, but more importantly, we want it to be strategic. So when we work with these hospitals, we have a couple of ways of doing it. One, we can just do a compliance review. I know that you've used BDO and BKD and some other groups that do that. Because we work in the rural space so much, we get into a detail of understanding what compensation needs to happen for rural providers in a way that those who just rely on survey data don't. So we can do those compliance reviews and can make that helpful. What we do is we read, I can say me personally, read all of the contracts that are with the providers. And I say, how does this match up with where you want it to be? Where do you want the organization to go? What can we tweak to get this closer to best practice? Does it mean that we need to pay based off of our patient panel size? Should it be, how should we incentivize? Do we have our ACO metrics incorporated in there, et cetera? So we come up with a report that tells you, here's how we would change our compensation plan. Here's the timeline and strategy for doing that, similar to what the practice throughput is. And, if so be it, then oftentimes we will help organizations actually go and execute that as a follow-on engagement. So I mentioned Randy earlier. It started out with, hey, we want to add, general surgery. How should we go about doing this? We've never employed a general surgeon. what should his compensation and contract look like. We drafted the contract for them and everything associated with that. And it turned into, let's have a larger discussion about our overall compensation strategy and how can we get this to fit our value-based reimbursement. So that's what we're talking about now. And we're going to look at every single one of their contracts and see what's the timeline to get us all on the same page. What changes do we need to make? And it's not just physicians, it's also APPs, because you can't just, you're not paying them an hourly rate, like nursing rate, like you used to. So hopefully, oh, look, I'm still at, I still have time left. So what questions do people have for the lawyer?
I'm wondering, have you ever done a learning collaborative series? Stepping a group of leaders through some of the key topics here, providing them guidance and maybe sort of coaching and providing feedback and doing a small reviews so that pulling them along and training them, but educating them, having it over a series of time, but maybe also working with some of them as needed on one-on-one. It may not be this in depth, but maybe it could be a little broader, or maybe it's a stepping stone, one of your first sections. Have you ever thought about it from that perspective?
Yeah, absolutely. We've actually already started doing that with some groups. Like I know within North Carolina, we've actually started that. And what we've been doing there was I start out with, here are the basic things you should have in a contract, right? From it when it comes to your provider. And here's the areas, here's the type of language that is a red flag if it's in your contract. So that way they can go back and look at their contract to say, all right, here's the things. Does it have all of these elements? Oh, hey, I'm missing it. And they can pick up the phone and call and say, and ask me, you know, we can do one-on-one training. But I've also said, you know, done in these, you know, kind of lunch and learn settings of if you're missing these types of components, here's how you can add them in. Here's where you don't need a valuation report, because it's not a simple matter of survey says. It's as long as you meet these types of metrics and document this, don't spend a bunch of money on trying to, you know, check a box. So we definitely do that as a learning collaborative. We've already been doing it in North Carolina. And I think there's Oklahoma and West Virginia as well. We've been talking to them about starting that kind of learning in those states.
Oh, that's great. Yeah, we'll probably be following up on that.
Yeah,
There's
but
a lot of good stuff.
actually on the practice side of things too, where I go over and be like, here's the top 5 mistakes that are being made and here's how to fix them. So that way they have it in a very learning strategy. And then, I mean, that's usually how a lot of this starts, is like, okay, wait a minute. I know I'm in violation of, you know, biggest mistakes, number 3 and number 5. Can we talk about that more in depth?
Bethany, also yoga has a lot of stuff on sleep practices and better sleeping ways and things like that. So any yoga guide can help us with this.
Eric and I have spent a lot of time together, if you can't tell.
And Opal, value-based care and incorporating that into and payments into provider compensation is also part of kind of the strategy as well, correct?
Yeah.
Yes, absolutely. Because we want you want your compensation to be flexible. Because here's the thing is, you can't go in and blow up your compensation structure every other year and said, okay, the ACOs had this change. Now we're going to blow up your contract again. How could you do that to your physicians? Right. So we actually design plans that can change with you. And then the physicians, when they know what the strategy is and where we're going, it makes sense. And you're not rewriting your contracts or blowing them up every year. That's also really legally expensive. You don't want to pay an attorney to do that.
Opal, just a quick question here. Do you find that the physicians actually understand the value-based payments? Because a lot of primary care physicians who are in accountable care organization have no clue about this. Is that, do they offer resistance? Is there a need for education?
So I actually, in my experience, I think a lot of them don't understand it. And that's why they have the resistance, is because the way that the messaging comes across is, you want me to track, for your ACO, you want me to track X, Y, and Z. I don't see the value of that. I don't see how it impacts my patients. And so you're just asking me to do something that reduces my productivity, which is going to impact my compensation. So we always start from an educational model of, I also like to, when I work with physicians, I said, always start the conversation, regardless of the type of engagement, of how do you think your community needs care? I will figure out how to do it in a regulatory and financially sustainable way, something that's compliant. But we're going to start out with you, physician. How do you think your patients actually need that care? Okay, now if that's how they need care, what metrics from an ACO, what ones would help you provide that care? Let's incentivize those ones and then show you how the payment system actually works. And once we do that, I've actually never had a provider say, nope, I still hate it.
You know, that's a terrific approach, because I found the same thing. If you can put it on that level of care rather than getting into the weeds with them, that's always the best way to go. Thank you.
And you can't just say, well, it's how we get paid. You know, that's not satisfactory.
Okay, thanks, Opal. And Carla, you are up.
Yeah, thank you. So the first thing that we wanted to go through was the emergency department throughput improvement. We all know that the emergency department basically is the front door to our organization, and can also, as we've heard many times before, be the window to our community. So if our emergency department has a bad reputation, many times that impacts the perception of the hospital in the community. So the purpose of this project would be to, along with a data request combined with provider and staff interviews, to look at the workflow and efficiencies of an emergency department. What areas are particular pain points to the emergency department, how that impacts your core measures or your MB-QUIP measures related to ED throughput and outcomes. So the goal is ultimately to evaluate the workflow and the processes to look for those problem areas. The objective of the evaluation is for recommendations to be made based on findings, providing the hospital with a written summary, including the findings, the analysis, and prioritized recommendations and actions for improving those areas. Also, along with a 60-minute debrief call with the ED manager or the selected membership of the ED team, the leadership team, and those that are chosen to participate by the leadership. Next slide. So at the end of the project, the hospitals, of course, will have the recommendations to help guide their improvement actions. The areas that are reviewed are from the start to finish. So registration, triage, the tracking of patients, what is the workflow with the provider and nursing staff. Laboratory and radiology are also very impactful in emergency department throughput, so we don't leave those particular areas out. The communication between the ED and the inpatient. At every transition within an organization, there is room for error. So the emergency department, when having to admit or transfer a patient, definitely those communication systems need to be addressed. Are we boarding patients in our emergency department? What are the admission processes and transfer and discharge processes? And then what does the documentation tell us? The emergency department throughput project can be completed within probably less than, but at least 90 days after receiving the data that's requested for this particular project. The next, Lindsay. Care delivery spectrum is something that we have started during this year to work with hospitals on really identifying what types of patients that they are able to keep. So creating your care spectrum helps you look at what are we keeping in our organization, what can we keep in our organization, whether it be an inpatient observation or a swing bed patient if they have swing services, and what does that look like? Many times we hear from hospitals that if Dr. So-and-so is on in the ER, he transfers everything out. And that's not good for the patient. if they can stay in their own community. And it's also not good for the organization if they could have kept that patient and cared for them safely there. We also hear that there is a lack of a consistency between the emergency department patients, the emergency department hospital doctors and the hospitalists. One provider will admit all types of patients in different services where other providers will not. So the goal is to help educate the hospital and coach them in developing their own care spectrum so they understand the type of patients and services that they have at their organization, and provide them with a written document that includes materials for them to use in hospital-wide training and policies and procedures for interdisciplinary teams to approve. Next slide. So at the completion of the project, each hospital will be able to develop their care spectrum. And this is an interdisciplinary team effort. We will conduct an educational webinar for the leadership and stakeholders, initiate a self-assessment that helps them really do a deep dive into what services they have, what equipment they have, what they have and what they can do at their organization, providing them with a how-to guide, having a webinar on the how-to guide and an audit tool, and help them to understand how to audit transfer charts or those patients that they have not accepted, maybe even in their swing bed program, as to why, and what they could do to make changes to possibly build up their admissions or their swing bed patients. This too will be completed within 90 days of the self-assessment and the information that we've requested from them.
And just a note, this is most beneficial to the clinical departments of the emergency room, to the inpatient, and to swing bed that we've seen.
Swing bed program optimization. Many of our organizations that we have worked with, and Eric had mentioned earlier today, do not maximize their swing bed programs for a number of different reasons. So with this engagement, again, consists of a data analysis with provider and staff interviews to really understand what's going on with the referral process, what's going on with their admission process, and why they're not optimizing their program. And there is a lot of variability across the hospitals that we see for many different reasons of why they're not optimizing their program. We will also make recommendations as to what they can do to help improve, their acceptance of their patients, and really understanding, again, adding into optimizing your program, what type of patients can we care for in our swing bed program, and what do we need to do to make sure that that happens. Again, they would receive a written summary with the findings, analysis, and prioritized recommendations and actions for improvement, and also a debrief call so that they understand what this really means for them and how they can move forward. Next slide. So at the completion of the project, of course, they'll have their written summary of recommendations to guide their improvements. And then they will also receive a training workshop to help identify the gaps in their referral process, which is where we see a lot of problems within swing bed optimization. How to market their program, what training do the nurses need, how does the information flow, and focus on the growth opportunities for their swing bed programs. I have looked at many different states hospital swing bed programs, what their population looks like in their community, and very rarely do we see hospitals that have maximized their swing bed program to the degree that they can. And that's very helpful, not only for the hospital, but for their community and their patients, to keep their patients in their community instead of sending them elsewhere. Any questions or comments?
Carla, after all these years, I just don't think that we will ever move away from ED throughput, technical assistance, and swing bed optimization. It's just, we'll definitely be continuing to work with you on these. And I really like the idea of being able to share early with the care delivery spectrum. You know, I would think, again, thinking 6 to 9 months out, where everyone is sort of getting through COVID, rethink payback, operations, and they're having to re-engineer their operations. That is definitely something that's going to be coming up, I think. Or at least I think so. I mean, do you see it?
Yeah, we actually, one of our first group addressing care delivery spectrum as a group has been with our hospitals in New York. And it's been an awakening to many of them, because when they started working on this as a group, they've been learning from each other, and then working with their interdisciplinary team within their hospital, getting the providers on board, the clinical staff on board, both the inpatient and the emergency department working together to really understand what they're turning away. And there is a lot of variability among providers. So getting everybody on the same page and talking through what we can safely care for at our organization is key. So that there's not, there's a lot of clarity there around what we can and cannot keep. And it also, one thing that I did not anticipate that we have seen and we've heard again this week from hospitals is, if we do not, in the small rural hospital, if we do not keep the acuity of the patient that we can keep, we're going to lose our nursing staff that really want to grow. The young girls and young guys that come out that really are energetic and want to grow their clinical skills are not going to be happy with just caring for just swing bed patients. Unless they want to work in that type of environment. They want to care for patients that are higher acuity. And if our hospitals are appropriate for them and can do that safely, then they need to, instead of sending them somewhere else.
Hey, Carla, it's Louise. The other thing that I would add that certainly was not, that I didn't exactly anticipate when we started doing this work, and that is, I think it's also led to uncovering opportunities to really look at consistency of the actual clinical care delivery. And specifically in the ED, one of the things that we have recommended as each of these hospitals start to do this work is that they identify what are the clinical, evidence-based clinical practice guidelines that your providers are using now. What are they using to help them to decide level of acuity and whether that individual is appropriate to retain or should be transferred? And what we are hearing is, gosh, we don't know. We don't know what protocols they're utilizing. And so we have highly recommended at the start of this process that they need to have that conversation, and ideally the organization will agree upon, okay, for treatment of heart failure, we agree we're going to adopt the American Heart Association standards, or whatever it might be. There are, published standards around sepsis management that have been identified as being really critically important. And so it's opening up that conversation and really facilitating intentional decision making around what are the guidelines that we agree we will adopt. We will do so in a consistent and uniform manner, and that will have a really potentially positive impact on the overall quality and safety of the care delivery. So I'm excited about that component of it, which wasn't necessarily really recognized when we started on this path.
Right. Yep, most definitely. And we had heard in several different instances, well, Dr. So-and-so, it's just the gut. He uses his gut. Well, there is a lot to be said for you just feel a certain way about the way that this patient presents. And we're never going to try to tell a provider what decision they should make. But it's just trying to make things a little bit clearer and more standardized so everyone knows what to expect.
I like it, for sure.
Thank you.
All
Carla,
right.
why can you tell me what to do, but you can't tell them?
You're very different, Eric. You're special.
Yeah, but you don't listen.
That's true too. Thanks, Lindsay.
Not to a bunch of clinical people.
Oh, all right. Next on the agenda is Louise.
All right, thank you so much. Well, let me just say first, right up front, as you see, I will touch on 3 different topics. I prepared quite a lot of material in the slides. I will certainly not be able to and will not try to cover all of it, but because a couple of these clinical models and programs you may not be really familiar with them, I thought it would be might be helpful to leave you with the material available as an ongoing ready resource via the slides. So the first topic that I'll talk about is a new service offering for Stroudwater, and we're really very excited about it. And it's a program specifically targeting primary care practices and helping them to improve management of their chronic pain patients who are on long-term opioid therapy. Just by way of very quick background, and as many, if not all of you know, the United States has been dealing now with an opioid epidemic for a number of years, and the statistics to me are just shocking. You see here, last year overdose deaths rose 5% from the year before, resulting in the death of roughly 72,000 Americans. And the year before, the data indicated that 32% of those deaths involved prescription opioids. And I call that out because this program that I'll momentarily tell you about focuses specifically on helping physicians and providers be better equipped to manage individuals who are on long-term prescribed opioids. And the last bullet on this slide that I wanted to call out, and that is the CDC estimates that over 2 million people have an opioid use disorder, and that approximately 20% actually are identified and receiving treatment. So huge opportunities to provide services to that population of patients. Next slide. So let me tell you a little bit about this new program. We did not create the 6 building block program, but Stroudwater has, we learned about this program, at least a year or so ago, have done some real delving into it and have really embraced it and feel that it is a valuable program for primary care practices in particular. As you see, the goal of the program is to provide an evidence-based quality improvement roadmap to help primary care practices implement consistent, effective, guideline-driven care for their chronic pain patients, again, looking specifically at patients on long-term opioid therapy. The program was developed by a team out of the University of Washington Department of Family Medicine and the Kaiser Permanente West Washington State region and their Health Research Institute. And just wanted to give you a sense of the importance that this program is really has been recognized for the strength of this program. It is now included in the implementation package for the 2016 CDC guideline. It was one of the first guidelines. The CDC's guidelines were one of the very first guidelines to come out, explicitly providing guidance to prescribing providers around opioid management, again, particularly focusing on chronic pain. And more recently, last year, the Institute for Healthcare Improvement also has now incorporated or included, I should say, the 6 building block program in their resource toolkit for that same focus of improving opioid and pain management. Next slide. So the 6 building blocks are as follows. 3 are here, leadership and consensus. As with really any kind of a major initiative, it is really crucial for the organization to have senior leadership support and buy-in and really active engagement to really demonstrate that this is a priority for the organization. The second building block is a major area of focus as organizations begin to think about implementing the sixth building block program and integrating it into their daily operations. It focuses on all those clinical operational elements that are so important: policies, procedures, workflows, tools, protocols being critical again. And so one of the foundational questions as an organization is getting started on this path is, it's similar to what we just talked about with the care delivery spectrum, is does the organization even know what if any protocols their providers are utilizing to give them guidance in managing this population and in prescribing opioids? So all of those are very important parts of the sixth building block program. Tracking and monitoring patients, being proactive in managing them, not just when they walk in the door or on the telephone, but on an ongoing manner and in a comprehensive way. Next slide. The other building blocks, and I should say this, the previous building block around comprehensive proactive planning, and then being really, again, intentional in terms of being patient-centered, caring for complex patients. Those are all very consistent with, those elements are very aligned with the patient-centered medical home model of care, and also with the team-based model of care. And I'll be speaking about the team-based model in just a moment. And so this program is very compatible and complementary to the patient-centered medical home model, but is really specifically then focusing on this particular subset. And the sixth building block is stressing the importance from a standpoint of ongoing quality control, quality management, and quality improvement, identifying key metrics for this population, and then putting a process in place to collect that data and monitor your success then over time. Next slide. I wanted to share with you very quickly the results. The team that developed this model conducted a clinical trial a few years ago is when they started on this work. And they started out with 30 primary care practices across the country, many of whom were rural clinics. And they identified common attributes that really led to a successful, highly performing practice. And so by implementing this sixth building block program, they were able to then measure some very specific quantifiable results. One was a reduction in the total number of patients on chronic opioid therapy, the COT abbreviation there. And then the second metric that's very important with this population is looking at the dosages. And the morphine equivalent dosage is the standard measure that's used. And the higher that 24-hour dosage, as you would expect, the higher the risk for accidental overdose and potentially death. And so with the adoption of the sixth building block program, they were able to demonstrate over time a reduction in both of those key metrics. Next slide. And then there was also a qualitative component that was recognized, and that is one of the physicians in one of those early practices that implemented the model found it to be very beneficial. And you can see the quote here, that it created that defined care path that reduced the level of stress and gave assurances that folks knew how to manage that patient more effectively when they walked into the room. Next slide. So in a nutshell, we have delved into and learned about the sixth building block program. In fact, we just completed some formal training with members of the original development team. We were very delighted to have established an ongoing relationship with that group. We have identified two different service offerings, basically. One is a webinar series, and you see a sample here. This is actually a webinar series that we have offered to a state network of critical access hospitals, and they are hoping to be able to do this for us to do this with them in the early new year. And it's really to train folks on the model. It can be a standalone single webinar of just a high-level introduction, or the deeper dive that you see here in this 4-part series, which then really equips the organization or the organizations in this case, to begin to go on that path independently, but provides that introduction to them. And, you know, I was thinking, Bethany, when you asked a question a few minutes ago about a learning collaborative, this would be a great example of how a learning collaborative could be so valuable as a number of hospitals set on this path, because this is a very challenging patient population with whom to work. And they can, as Carla already said and Lindsay said, it's a way for them to then learn from each other as they go down that path.
I just jotted that down. I was going to ask you about it. So in fact, I was just jotting. So, oh gosh, we got to put this one down for our future quality training. So yes.
Yeah. Yes. And I can tell you that has actually happened. The team, again, out in Washington State, they basically, as you might expect, since there's an academic group involved, so they're very academic and kind of research oriented, but they have actually established in the state of Washington a collaborative, I think one or more collaboratives specifically around helping primary care practices and hospitals manage this patient population. And then our second offering is very similar to what you've heard of from us already. Lindsay, if you want to advance the slide, actually the next slide. Our second offering is really around not only education and training, but then also implementation support. So very similar to the kinds of things that we do on the quality assessment side and some of the examples that Carl has already shared. We do start with the same sorts of steps, that high-level desk review. What is current state? We conduct interviews, and something that we have done now in the context of COVID, where it wasn't possible to be on site and do direct observation and talk with the direct caregivers and the providers to understand really what were they currently doing and how they were doing it. We have developed a survey conducted by SurveyMonkey, and that has proven to be a really useful and helpful tool. And then the staff can do it, kind of on their own time in between patients. But it was a way for us to really gather a wealth of information about current state, and then to look at that in relationship to the identified best practices, recognize gaps, and provide a set of written recommendations and improvement opportunities. Again, looking specifically and utilizing as a foundational element the CDC opioid prescribing guidelines. And so you see, we walk through those steps here on these next two slides in terms of our steps in providing that sort of implementation launch support. Next slide. One of the other aspects of the 6 building block programs, the development team has developed just a wealth of materials that are readily available, and they are just thrilled that we are involved now in really helping to educate providers across the country in this model. They are deeply committed to improving the management of patients with opioid disorder. And so they have been very open to sharing a wealth of materials with us that we in turn then are now able to bring to our clients. And then typically with the kinds of things that we already do, an action plan is the last step in our process to help them to develop then an action plan for actual implementation of the model. Next slide. So the next topic that I have to talk very briefly about is the team-based care model. And I want to say that one of the things we have learned is that that phraseology of team-based care is a generic term that is just now very widely utilized. And it's incorporated in the patient-centered mental home model. It's utilized in the 6 building blocks model and their materials. But there is actually a specific program or specific model that has been embraced by the American Medical Association that is called the team-based care model. And so we're talking about that model in this regard, and it again focuses predominantly on primary care. The statistic here I wanted to call out is just a recognition that currently and historically there has been very low allocation of of funds, if you will, to support primary care. The tendency in this country over recent years has been really all about specialty and subspecialty care. But that data shows that by increasing the spend on primary care, it can actually have very beneficial results, not only on the overall health of the population, but in reducing overall healthcare spending by reducing some of the what may be unnecessary specialty care, and certainly keeping people healthier out of the emergency department and out of the hospital setting, which are so important in an overall value-based reimbursement environment. And you see some statistics here of states that have found that by increasing the focus on primary care, it has led to overall healthcare savings. Next slide, please. So that's really the background in terms of why does this matter? Why does it make sense to really focus on strengthening primary care and on primary care delivery through a model such as the team-based care model? So the core goal of the model, or really the focus of the model, is on assisting primary care practices to restructure the way in which they deliver their care and services. So looking at and restructuring clinical processes and workflows with the goal of really increasing the distribution, the sharing of those responsibilities across the whole team, freeing up the physicians to really do physician level of work at the maximum amount possible, and likewise advanced practice practitioners, nurse practitioners, physicians assistants, as well as your nursing staff. You're really, in some cases, scarce and valuable and most expensive resources. Fully utilizing your support staff and doing so in a very organized team-based way. Potential benefits you see here: improving practice efficiency and productivity would be top of the list. We have also had direct experience with clients who, by making some of the changes that this model recommends, they've been able to actually identify and increase their productivity by better utilizing and opening up some capacity for same-day appointments and urgent care appointments, which has led to increased visit capacity and in turn can lead to increased practice revenue. So there are some very quantifiable benefits of this model, as well as I've already mentioned, increasing the focus on providing comprehensive coordinated care. Next slide, please. There are 4 core components. I won't go into all this, but again, this is a very specific structured model in terms of this particular team-based care approach, with very specific elements that are identified here. The one that I would say is probably the most important from the standpoint of increasing productivity and capacity, and that is that idea of having the co-visit, which you see there in that bottom right corner, the leveraging the 4-stage office visit. And by that, I mean that the patient, while the patient is being seen in the clinic, a clinician, a nurse, a medical assistant, but a clinical staff person remains in the exam room and performs real-time documentation while the physician or the provider is examining and interacting with the patient. And so that really is at the heart of this model and is not necessarily the case with other team-based care approaches. Next slide. So similarly, we have the same 2 sets of offerings. We can do just the education and training for practices or for organizations who want to learn about this but aren't ready to really dip their toes in the water yet to implement. And so we can do a 1-hour intro, we can do 2-hour learning sessions, 4-hour learning sessions, with each one obviously a deeper dive and a more comprehensive look at the model. And then we also do provide team-based care as from the standpoint of helping practices to implement that model. We have done this work with a number of different practices, both in the critical access hospital environment, as well as a large multi-practice, multi-specialty clinic in the south central part of the United States, which now also has a physician-owned and physician-based ACO, so that this model is really is relevant in really all sizes of organizations. Next slide. And then we also do, and in those instances, we did the initial orientation and training, but then we've done implementation support and all the same kinds of steps that I've already spoken about. One of the things that we have found is really important for implementing a model like this, because it's directly impacting your direct caregivers, your providers, and the staff assisting them. And so we strongly recommend that the clinics or the organizations conduct a kickoff meeting and bring everyone together so that everyone is basically learning and hearing about the program and what it means and how it will change their workflows and how it will, with implementation, really hopefully improve their work life and also be a more satisfying experience for the patients. Next slide. And so you see here the start for my third topic. I think I have a couple more minutes here, and I'll do this one really quickly. And that's the importance of care management. And this will be really the most familiar to you, I would think, Bethany and everyone, because this is a part of what we do now when we do any of the quality improvement assessments. But this is really taking care management as a topic and doing a deeper dive and a more focused look at how care management functions are being handled. And certainly we touch on it in the QI assessments, but the goal here would be to be more focused and really looking at how is care management being handled across the organization. We touch on that now. You've probably, I know, you've seen some of our book. I know you've seen some of these recommendations in our reports. But if the organization has, they have a full range or a pretty large number of the elements of a continuum of care. So how are they really doing at managing these patients, again, from a proactive, comprehensive way across their own delivery system? So how are they communicating and coordinating and collaborating with each other as patients move across their delivery system and as they move in and out of their delivery system? And so those are areas that we particularly focus on in this service offering that we aren't able to do to the same extent in a broader QI engagement. And so next slide, please. So again, the objectives are to really help the organization to evaluate and to then beef up, strengthen their overall care management processes, developing and adopting clearly defined care management roles and responsibilities, care management processes. Carla and I were talking about that just yesterday with a client where there was a question about how well the nurses on the floor were communicating and collaborating with the care managers. And so what does that look like? What does that mean? Again, consistently or similar to what I've said about the other two models, standardized workflows, tools, communication processes to really improve the effectiveness and the efficiency of the work. And then lastly, that focus that I've already talked about on patient transitions of care across the delivery system. Next slide. And so for this one, this is really more of a helping by getting in there, doing that sort of an evaluation, assessing current state, and then doing education and training and facilitating a performance improvement development of an action plan, very similarly to what we do now with QI more broadly, as I say. Next slide.
I think that's it.
I was going to say, I think that brings me to the end. So any questions? I know that was a lot. I packed a lot in and hope that was helpful.
It was very helpful. So of course, I have all these questions going. I'll try to be quick because I want to make sure Lindsay has time to speak as well. So it sounds like to me that both the team building and then the 6 team-based approach and then the 6 building block could be done as even maybe a 2-step, a virtual training series as you suggested.
Yeah.
And then if they completed that, and if it was the appropriate hospital, if they followed up, if they completed that, then maybe we could have additional step down. They could have some more of that one-on-one direct TA.
Absolutely. Absolutely. And in fact, again, because of COVID, we are working with a critical access hospital right now to help them to develop and implement the 6 building block program. We are doing everything virtually. And so we've done the kickoff call, we've done planning meetings, we've done all the interviewing, and we have done the SurveyMonkey survey and the desk review to look at current state, and then are helping them right now to develop their action plan. So we can do this all virtually, and had to really develop those tools in this environment. But I've been pleasantly surprised at how much we were able to really learn, particularly through that SurveyMonkey survey.
Oh, that's awesome. So yeah, I really like that. Regardless, these are areas and topics that we know we need to address at least some time, at least for open trainings. And then it's just nice to say, gosh, there is an opportunity then, say maybe for additional step down or more of an intensive and learning collaborative where it's still virtual or where you do have some one-on-one with them. So we'll be following up for at least somewhere in the future for some at least trainings as a place to start. Sure.
Well, that's great. And I will say that I think for so many of these organizations, for really any of these initiatives that we've talked about today, because folks are, they're spread thin, they don't have a lot of bench strength. Everybody's, they're juggling 10 things. So we can come in and help them to get focused and to really develop that action plan and figure out, okay, now I know this is, it can be overwhelming, but if we take these 3 steps, we're going to be a lot farther down the road than we were, 6 months ago. And so having outside help to facilitate that, we find just really helps folks to accomplish things they want to do and are trying to do, but are having trouble getting organized to do in that systematic way.
That's great. And then I think in terms of, again, sort of one of the purpose of this is helping us to be aware of the services. And I know that Stroudwater team has, gone through your own learning curve about how to re-engineer the services to meet these new times. So this has been really, really helpful. And so I just shared that thinking that really want to also go back. I want to sum up really our ITA. What is that? We've shared it before. And so Lindsay, when you're finished, I think I want to sort of wrap up and give team time to have questions, but I want to go back to that because the ITA, we really want it to be tied to those FOA, QI recommendations, the revenue cycle, leadership development, some of those pieces. And so that care management, that deeper dive, that next step that you just shared, I feel like that gives us the right information so we can help steer the hospital. This is your next step. If you want assistance with care management, here's how we can really help you. Here's your next step. And so that was really very helpful.
Good.
So I'll be quiet now. Lindsay.
Okay, thanks, Bethany. I think you gave me a good intro about taking that these ITA projects are taking something from the action plans that come out of the QI assessment or the SFOA. So, and one of those is around the development of a patient and family advisory council. And so I'm glad that you have some of the your care coordinator team or community champion team on, because I think this service offering really supports some of the roles of the community champion that is part of this project. I think I and some of the other folks that have been very embedded in this project understand kind of the role of the community champion. So I think this kind of speaks to that. But really, the Patient and Family Advisory Council is an opportunity for the hospital. Maybe they are struggling as it relates to their patient satisfaction, and there isn't they're kind of, hitting their heads against the wall about how do we improve our patient satisfaction? Well, one of the opportunities is to gain a better perspective and understanding by collaborating with both patients and families to understand some of the care that these patients and families have received, and to improve kind of the processes, procedures, care delivery, and outcomes for the hospitals, and collaborating. The most important thing is around collaborating with the patient and family. So the goal of this service is to really assist the hospital in the development of a patient and family advisory council. So we call it a PFAC. Some of the main objectives is to first, from an education standpoint, is to understand the concept of what this patient and family advisory council is. What does it entail? What are the commitments of members, of the folks that are on the advisory council? How do you create this council? Who do you select for members of that? So understanding some of the core concepts of it. And then understand if the hospital is actually ready to. Maybe this is not the opportunity for them to jump into something like that, and they need to focus on more strategic, clinical care delivery. And so, developing this council is not something in their cards, but we want to help the hospital kind of get to that point. And then the ultimate goal of this is to create a implementation strategy. So that action plan of how to implement this council. What we will provide, again, as part of the objective, is the education and also facilitate action planning for the implementation of the Patient and Family Advisory Council. Some of the anticipated outcomes is that the hospital will have an implemented council, and that they'll be able to bring together, their patients and their families and improve some of their outcomes. On a measurable standpoint, there's probably, improving on their patient satisfaction. Our methodologies around this is really to do the education webinar. We'll hold interviews with key stakeholders and have some planning calls with them, and then as a group develop that implementation strategy with them to implement that patient and family advisory council. So that's it. That's the quick wrap up. Any questions?
And let me add to that too. Some of our recommendations when we've talked with our hospitals around Patient and Family Advisory Council has also been looking at if they're not ready for that, then how can we help them with a focus group? Mm-hmm. In my past life, I needed to do something in my OB department, and so I just had that one focus group that was patient family focus group with just OB. It wasn't an overall. So just kind of trying to gauge that. I just wanted to add that part to it too.
Yeah, and we think that to be successful and doing some type of engagement with your patient and your families, it needs to have process, and it needs to be structured, or it's not going to happen. Or it will, but it won't, withstand the test of time. So having some of these guardrails put up in a process and an outline to implement it, I think will be important for the organization.
I think this is another great TA service to offer. We know it's just about on almost literally every report. It's just something that is so darn needed. So maybe it's also something that we roll out more broadly, as a specific training if possible. And then even just then we can help push it in that direction, and not just from helping them to also understand it's just not a focus group. There needs to be some clinical decisions, like you say, behind it, or the whys behind it. And it's still clinical care, and not just pushing it out to the community. I think this is a great suggestion. That's a great follow-up. So the ITA, and I apologize, I wish I had thought about just providing a brief update before, just to get us all thinking, but that's okay, we can wrap up. You know, what you're sharing are great ideas and very helpful for us. We've got so much going on. I think this has been very educational to us. Our team is expanding, helping you to get to know our team, help our team to get to know the Stroudwater team as well and understand the broad services so we can start speaking with one voice. And when we're working with our hospitals through this program, through some follow-up, you know, now I feel like we have some well-structured conversations that when the hospitals want to request an implementation TA, that we have really made improvements to say it's got to tie back to your FOA, your QR action plan and report. It's got to tie back to your revenue cycle, physician practice management. It's got to tie back and support at least one of these areas, and community care coordination, workforce development, telehealth. I think what's really came out of this, I mean, because everything's applicable and we have a nice list and talking points, we can speak to it now when we're talking with the hospitals, but we can really target how we can help them and not just let it be a free-for-all wish list, because it was really getting out of control. 2017, we really did sort of promote it as what's on your wish list, because we were just doing anything to engage that particular cohort. It was like pulling teeth, but our cohorts are becoming a little bit more progressive, particularly the 2019, and they're like after everything. And so now we're trying to boil it in and get it structured. So I think this has been extremely helpful today. So I have been the one to do all the talking, and I'm going to be quiet because I really want our team to provide comment and ask questions and share some thoughts as well, if any.
I know we don't typically work with you on the community care coordination side of things, but I'm glad that you showed some information about the PFACs and talked a little bit about the focus group. We do community connect events with hospital leadership and partners, and that need is coming naturally out of the leadership the more that they're hearing from their community members. And our 2019 cohort of hospitals is starting to recognize that the service area demographics are not necessarily the demographics that they're seeing of their patients coming in. They just don't match. And so they're trying to figure out how they start to address that, and having a stepwise approach would be really helpful.
Good to hear.
Yeah, I will just say, since you brought up the fact that, you know, sometimes the demographics in the community are not matching necessarily always that patient, we actually are rolling out our updated market assessment tool that actually specifically is addressing some of those needs of identifying, hey, you know, you have this market share and such, but here's all the people who you don't are not getting care anywhere, because, you know, and breaking it down by demographics so that you can see and you can actually brainstorm around how can we have outreach into those communities, rather than just assuming they're getting care elsewhere. They're really not getting care, and it's causing problems in our communities. So
will that be included as part of the FOA then, this updated or this newer version of the market analysis?
Yeah, we're working on the refinements of it over in this next month, and I think we're going to be rolling it out beginning of next year. So.
Oh, fantastic.
For everybody at Stroudwater who that was a surprise for, by the way, like you didn't hear all about it on Monday. Sorry.
What are you talking
It's one
about?
way to announce it.
I know I announced it to this group before everybody else, but
No pressure.
they're getting the full learning experience of it on Monday. They get an entire course on it.
We'll
So
still act surprised. You know, we'll still be surprised.
Lindsay, do you know anything about this?
No, nobody checks with me about anything anymore. I'm beginning to feel like you.
I know nothing about this. I think I'm just gonna go tuck my head back in my shell.
So, pun intended. No,
Good one,
but I
Bethany.
just really do want to say we use those market analysis. We use them for, you know, on various aspects of the program. So in fact, particularly with the FOA and the QI, just to let you know that, you know, we know that it's such a foundational assessment. It really does get done first, and then your reports really do get used for, it gets shared back out with community care coordination team. It gets used for planning for ITA. It gets used to support telehealth. So Huron looks at them to support the hospitals with some of their background information for the telehealth, and now you know, we're really using it also for determining impact. And then so if we have that little piece of it, I think that's substantial. So that's great. And leadership development.
And Bethany, it's Louise. I failed to mention, but Opal reminded me, we're also actually, we're working with our analytics team. There's a wealth of publicly available data related to opioid usage, prescribing rates, overdose rates, death rates. And so we are, as we speak, looking at ways that we can actually create some reporting around that. And then that would be potentially added in as another slide or two where it's applicable in the market assessment, because that, again, it just helps to inform the healthcare decision makers about this is what we're dealing with in our market, in our communities, as it relates to opioids particularly. And so we're looking at incorporating that in our 6 building block work where we can.
Oh, that's great. And even if it's I can easily see, and I'm speaking for Selena, Karen, so you ladies just jump in here, but I'm just speculating. I'm seeing a scenario. So think about one of the communities where they're, you know, where they're concerned about drug abuse or opioid. And so if we needed until it sort of comes on to the point like you talked about, then maybe we even just support, say, a feasibility type study, if that's what we need to call it. So it's a minimal report so that we have the data to support, say, by community or something. So ladies, you can sort of keep that in mind if you think that would be helpful, because I would say it'd be great information while you're working with the communities.
Yes, and the CDC, there is data published for a number of those elements that I just mentioned at the county level by state, because there's been so much attention nationally to the opioid epidemic for a number of years. There is more robust data for that than there are a lot of other, you know, chronic conditions. So that's what we are really looking at, how we can harness that and bring that, you know, to as we're working with folks in their communities.
That's great.
So we and Keith is actively working on this as we speak. So in the not too distant future, I think he'll have some a couple of report templates that we can share with you.
Fantastic. Terry, I thought I interrupted you.
I just had an observation here. You know, the great management guru, Peter Drucker, said, hospitals are the most complex organizations in the history of mankind. He said nothing's even close to being as complex. So what I heard here is just, it really takes a multifaceted approach, because this stuff is so complex. There's so many different cultures within it. And what I love about the Delta program is, as you guys just observed, there's so many parts, and if you're just dealing with one, the other one is going to go haywire in that regard. So being able to kind of manage those various parts is extremely important. But also within the Delta program, you know, we're working in the community as well, and all of that work is going to pay off big time. The population health side of it, EMS is another component, telehealth, et cetera. So I've never seen a federal program that's as multifaceted as this one is. And speaking of CDC, About 6 months ago, they approached the Federal Office of Rural Health Policy and said, we'd really like to take more of a systems. Can you give us any examples of rural that is doing kind of a systems approach? And, you know, we've been doing that since day one of this program. And I just think that there's nothing out there quite like it. And it's so great to have the partnerships with Stroudwater, and BKD has also been a really good group to work with, et cetera, Huron. I think it's the most exciting program personally that I've ever been involved in. Just wanted to say that, and thank you guys so much.
Thank you, Terry.
Thanks, Terry.
Yeah, thanks, Terry.
So what about any other comments or questions from Delta team? You know, is there a resource you're thinking that you're hearing that maybe they didn't speak to, or did you hear something really resonated that you think, gosh, I've been working with the hospitals, this is it? Or something you want to connect back with one of the Stroudwater team members and be creative?
I don't have any questions, but just thanks to the whole Stroudwater team. It's really helpful just to see the kind of the gamut of things that you have to offer. And yeah, I've heard a lot of these come up, so it's just nice to know kind of what you all can offer. So this is really helpful. So thanks.
And I was just going to add, I appreciate you guys talking about care coordination. We don't get to listen in on those talks as frequently as the consultation team. So it's good to know the capabilities of your staff, and also, you know that we can listen in the future for opportunities to get our champions involved and kind of expand what the hospital is doing too.
Absolutely.
Well, good. Well, I think we ended early. I didn't think it was possible.
You did great.
And we could record Eric's presentation again now. We're back to minutes.
Yeah.
Okay, well, everyone else can
Everyone's
leave.
going, oh. Love you, Terry.
That's right, Eric.
Yeah.
You get another 10 minutes.
Yeah, Lindsay threatened us to keep us within our time frame.
So thank you all. I will send out the slide deck too for you all to have.
That would be great. Absolutely. I think that helps us, again, speaking with one voice, helping us to, as we're hearing back from the hospitals and what their wish list is. And you can say, well, you know, we really can, this is what we really can do, and help direct them to the best services. And clearly this is something that's impacting all the recommendations that we're seeing. So we know this has been a lot of work on Stroudwater Park, and we're very appreciative.
Well, thank you. Thanks for taking the
Good to
time.
do it.
Bye.
With that,
Thank you.
All right.
Okay, guys.
Bye, guys.
thank you.
Thanks,
Have a great
everyone.
day.
Bye-bye.
Bye-bye.